Good day, and welcome back to our series in Faculty Development, Teaching and Learning in Medicine. Today we'll be exploring the concept and practice of precepting. In the practice of precepting, we find ourselves as clinicians both supervising our trainees, generally residents and medical students, supervising and teaching, performing clinical teaching. And I'm really happy today to introduce Dr. E. Faber, our senior faculty member in the Department of Family Medicine. Welcome, Dr. Faber.
Thank you.
And in addition, we have our former medical student, fellow, and junior faculty member, Dr. Marcia Edmond. Thanks for joining us, Dr. Edmond.
Thank you for having me.
How important is precepting in your role as a faculty member?
So I think that precepting is the most important teaching that I do, because I think what we're trying to do primarily in family medicine is train people to be good physicians in the office, right there where family docs spend most of their time. And the best place to train them to do that is in that place. So I think the inpatient medicine we do is important, the didactic lectures we give are important, but really it's all about helping the residents do a better job with the patient who comes to see them in their office. And that's what you do in precepting. It's the supervision of every single piece of it and the modeling and helping them to think through the problems that they're going to face in the office in the future. It mostly happens right there in that room.
So I guess, Dr. Edmond, of all of us, you're now 2 years into being an attending, so you're getting up there. If you look back, how important was precepting to your clinical learning? Because you had me bothering you when you were a fellow. For 3 years you were a resident here, and you were really working with our department for a good portion of your clinical training as a student. How important is that precepting to the learning, the formation of the young doctor?
When you're there, as a resident, you're kind of tunnel vision. The patient is before you, something you're a little bit nervous, not sure what to do or what to say. But then you have your way of managing the patient, or you think you should do that. But when you go to the attending, they kind of give you a wider scope of things you missed. So they help to zoom you in. Sometimes they may agree with you, and then sometimes they will differ. They explain why. And so you get to learn also of different ways of approaching that problem with that patient and incorporating other things that you didn't think about. So it kind of helped to refine the taking care of that patient better, and also have you learn of other ways that you can approach the problem. Or it was very, very important for me in taking care of outpatient.
So it sounds like precepting is important, and I can tell you that in my role of chair, you've heard me say many times that the most important person in the hospital is the patient. The most important person in the medical school is the medical student. The most important person in our department is the resident. And residents have come here to learn. They've come here to learn our trade. And precepting in residency is very much along the model of an apprenticeship. And it's not only in family medicine. For people who are trying to learn about precepting, the kind of skills and techniques we're going to look at today really cut across all clinical training of residents. Unlike everything else, we have our goals and objectives. We want to enhance our residents' knowledge and even our knowledge, skills, and attitudes. We want to enjoy what we're doing as we teach and supervise care in the outpatient setting. So already we've seen precepting as two jobs rolled into one, supervising and teaching. And we have to remember that we're teaching adults, and that's going to be a part of what we talk about today, to really understand what precepting means, what are the challenges, to think about our own teaching style and how it's changed along the way, and to make the job really more enjoyable, and that's what we're here to do today. So I guess the first question is, what does learning mean to you? How do you know if a resident's learned?
But if you remember telling the resident something maybe earlier in the month or the week before, and now the resident come and you see they're actually expanding on their reasoning why they're giving this medication.
So the residents have actually taken information that you've taught them, and they're using it in the care of the patient, and they've changed their behavior. And a change in behavior is always learning. So I guess, Eve, how do you know when the residents have learned?
So I make a point of always saying, what about that? What are you thinking about that? So that I can gauge where they are and try to target what I'm teaching them at that moment to what they need. And it's not always about what year they're in residency. You can find a third year who's a great third year and who doesn't understand something really basic. So you have to be sure you figure out where that person is for that interaction each time too.
So you find that, in a way, precepting is very discreet. It's not only for the patient, it's specific to the condition. And I think a lot of us as preceptors can kind of go down the road, well, this is a really strong third-year resident. We don't need them to really present everything when we do, because there's always something we can teach them. And I think what's true about precepting, and probably even more so, is that, again, we have these two sides that we walk down. On the one hand, like the screen, the preceptor is trying to pull those residents up. How can we get them to improve? How can we get them to expand their differential? And yet at the same time not lose the big picture. And then the other side is the patient. And in the hospital, the patient always has to come first. And we've said this many times. You know, Franz Reichmann says, clinical teaching is unique to the entire realm of teaching. Because in no other field does the nature of the material demand this degree of the teacher being prepared, but without any preparation. So I guess, Dr. Edmond, the question is, when you were a new preceptor, how did you feel about the fact that you can't order your patients to come in with diseases? They're going to come in with whatever they have. That's what the resident is sort of going to be encountering. How do we prepare ourselves for anything can walk in? Bad CHF, MI, bad asthma, somebody who's depressed. How do you prepare? You can't.
You can't.
You do what you can.
You make sure that every time you see something unusual, you look stuff up, because that's your preparation. Your preparation is what happened 2 weeks ago when something similar came in. It's reading the journals. It's not before I go to clinic, I better make sure I look something up.
Like
you
medicine.
can't do that.
It's like
you
medicine.
just have to be at the top of your game, and you have to know when there's something you haven't looked up recently and check it out, or something you're not strong in and get some help, because maybe it's a rash you haven't seen and you ask another attending. You know, you have to be open to saying, I don't know everything, and nobody can.
Well, I think, that's interesting, because the way you prepare to precept is the way you prepare for medicine. You realize you're a student for life. You're always learning. And you said something interesting, because when I first started working in faculty development in the mid to late 80s, I used to tell faculty, don't be afraid to go to the books and look something up.
That's right.
Because then residents will see and medical students will see, hey, this is how you learn. You keep up with things. Nowadays, you're right. You don't go to the books. You go to the computer.
I have a tendency to kind of put myself in that position. What would I want to get out of it if I was presenting this case? Or I kind of reflect back when I was a resident and went for precepting, how I felt if the preceptor yelled at me or spoke too loud or whatever. So I try to go back to that and speak to them softly, have them sit down instead of standing up feeling like they're. So I have them sit down and say, come talk to me, what's going on? And then I'll go in with them. Depending on what the problem is.
Into the room to
Into
see
the
the
room
patient.
with them and go in to see with the patients.
So as a senior preceptor, how often do you go into the room with the resident?
A lot more often with the first years than with the second and the third years. I mean, with the PGY1s, they're not going to have more than 3 patients. So every patient needs to have a lot of depth of teaching for it. For the third years, I'm looking more at, there are some really routine things that I know they can handle. So I might ask a quick question, make sure they cover the bases, but I'm looking for those unusual cases to make a bigger point of them. And those are the cases where I might go in the room, for sure, if there's physical issues, physical finding issues. But I also might sit down with them at the computer and look up, gee, we haven't dealt with this in a while. Let's see, are there any new guidelines? Is there any new research? Maybe it's been a year since we saw this before. Let's make sure we're really doing everything up to date. Sometimes I do it just to go through the process of showing them, this is where you're going to find this, because 2 years from now, the answer I give them now might not be the answer, but you're still going to know how to look for it. If it's a USPSTF guideline that's updated, you still find it the same way. So I say, gee, if you don't remember, this is how you check it out. Even if I just looked it up and I know the answer, I think it's better for them than just having me tell them, because then they can go away.
Often when I teach medical students here, I'll use what I call the Price is Right model. And rather than give them the answer, I'll say to them, well, what do you think the pressure in the eye is? And you have your opening number, and the students start to giggle, and they say, well, I think it's 100. And I'll look at the next student and I'll say, well, what do you think? You think it's higher or lower? And then, because you really want to generate some thought, because if they don't have a standard to go back to, as things change, they won't understand. And we
Yeah.
really want to promote understanding because it's an important part of learning. And, you know, as we learn in clinical medicine, there's always the tripartite: cognitive objectives, the knowledge; affective objectives, the attitudes; and psychomotor objectives, the skills. They have our attendings to model to. They have people that they really respect.
I think a lot of residents come in very nervous, and a lot of times maybe what we see in the beginning isn't really their approach to life. You know, maybe they're just acting as if they're a little anxious, because I do think that we can see a lot of change. I think that the residents can learn different approaches to dealing with with difficult patients, for example, you know, where they might just like run out of the room in the beginning, and they can learn to sit there and have the patient be angry for a few minutes and deal with that and kind of move on. Like, that's an approach we teach them often with those patients. So there are definitely things they can learn.
So they can change their attitude.
They can. Hopefully they come in with an open attitude towards learning.
You know, psychomotor skills, in terms of our skills, I see somewhat of a change. I really think a lot of what we do for residents is model, and a lot of what we do is show them how to learn and how to apply knowledge to the clinical scenario. And I don't know any area where that's more important. That's my shopping cart for cognitive skills, and that's what we look. You know, what is the basic knowledge, and what's more important, to have the pieces of knowledge or to understand them and to be able to use them? And there's no better place to use them than on the patient.
That's right.
But you can't synthesize until you know the building blocks, and that's why we have to push them sometimes to go do the reading and do that level of stuff too.
Right, even if it's opening the computer and reading it right
Right.
there with them, applying it, analyzing it, synthesizing it, putting it to the patient and evaluating. And you know, one of the things when we're teaching cognitive skills, how do you test? You know, as you're going on and teaching a cognitive skill, you've gone through it, you've applied it to the patient, how do you think you might really test? Because you can't ask the resident. Well, you do understand that, don't you? Because what the expected answer is yes. Who would have the nerve to say no? So how might you test that?
Well, you can change something in the scenario hypothetically. You can say, what if she wasn't on that medication, or what if this was different? If you just twist a little bit of it, it forces them to go from A to Z again and to use the process. That's one thing that I do.
So it forces them to apply under a different circumstance, and you can tell. And that's often a really great technique in terms of understanding.
If I'm trying to pull something out and they can't, and I don't get it, and I might tell them, then I'll say, why do you think I said that? Or why do you think we're going to make this decision? And they'll say, because you're thinking about so and so and so. And that get them thinking of, have an idea why I would make that decision. The decisions that they make sometimes, and I'll ask, why do you think I say that? Or if it wasn't this, why would you think we'll do that?
So to ask for reasoning, to change the clinical scenario. I think another thing that a preceptor can do, and both are great suggestions, another thing is to look at the resident, to use their body language. You can tell when they're struggling, you can tell when they're anxious, you can sort of tell when they're not sure, and you can tell when the light bulb goes off. And I think in part, when we're asking them for the reasoning, when we're trying to get them to think along the continuum, to develop the knowledge, to then use it, and then to be able to test it, the body language that the resident uses is very important. And often we'll be looking at the patients or looking at a computer, and one of the problems and one of the challenges a preceptor faces is that they are multitasking. You're trying to discuss, you're trying to describe, you're trying to explain, you're trying to demonstrate, interpret, and predict, and you're into this teaching thing, and you have a nurse who's telling you, but I have a patient right now, and she looks like she's having trouble breathing or she's bleeding. Can you look at it before I take it to the emergency room? By the way, they just brought this lab. So-and-so needs a prescription redone.
Sometimes there's a line.
And you're in the middle now of distinguishing, classifying, comparing and contrasting, really trying to use that information, synthesizing it, putting the pieces together, and you have all these competing interests. So it's not easy to precept, but I think you're right. You have to keep your cool. You have to prioritize. And sometimes folks just have to wait, especially if you're in a critical point in a case, bringing a resident along, dropping that case all of a sudden will just lead to a disjoint in the thinking. It's a juggling act. And this is what we were talking about in evaluating whether or not your learner has really grasped the information, understands it, and can use it. You can assess, you can justify, choose a different scenario. And again, always be looking, trying to get those cues, like where is that learner at? Now, it's easy to get upset. It's easy to become angry, and it's important that the residents not see that. I mean, you can have these feelings, but it depends upon how you really act on them. Because if you get upset, that resident is going to be sort of think a second time before they come and present a case. Well, how do you feel when a clerk comes up and says, Dr. Edmond, are we leaving at 5 o'clock or are we leaving at 6? I need to know. I have kids at home, you know.
Well, I said, you know what, I'm doing the best that I can, and I go and assess the residents, see where they are, I assess with the nurses, how fast are they triaging the patients. Sometimes I help the residents with I go in sometimes, even before they come out, if I see they're in there too long,
If people are really not doing things that are helpful to the process, and they've been already told not to, then you do need to make a point that that's wrong and pursue that if it needs to happen, because otherwise it'll just come back on you. So if you let those interruptions distract you from the case you're precepting, it's going to keep happening. And if instead you say to them, right now, I'm going to need to do this first, and then I'll come back and really address the issue, I think it makes things move more smoothly. And definitely, I'll have residents where I say, I want you to go in there, I want you to spend 10 minutes taking a history and come out and talk to me.
I have to do that.
Because I know that this
limits.
is complicated, and I know you need some advice before you spend an hour with the patient. And if they don't come in, I'm going to say to them, I told you to come out in 10 minutes. That's why I came and got you. This is why I did it this way, but next time I ask you to do something, I want you to trust me. And I want you to do it. You know, be very clear and very firm. Like I said, you never yell. You never yell, but it's not always light. It's serious business, right? If somebody lets a patient sit around complaining of chest pain with the high blood pressure for 2 hours before they tell you, they need to be told that was a mistake and they should never do it again. You know, we're going to deal with it, but don't do that.
So you're right. It can't always be done in a kind of light way. Sometimes there are serious things. You pick your battles. You don't yell, because yelling never, and yelling is not going to convince them anyway. They'll just think you're
make it worse.
And then it makes it worse, because then they go in and close the door and they're never going to come out and precept with you. And that's not what you want. And, you know, we do teach some skills. A lot of the skills we teach are communication. But there are also some other skills, biopsying small lesions, giving injections, knowing when and how to do things. And I think probably for surgical precepting, this is a lot more helpful. But, you know, when we're teaching a skill and you have a new learner, a level 1, you definitely want to be the one that does the procedure while they watch. And then you want to be at their arm while they're practicing. That's a level 2. For level 3, you want to keep an eye on them as they're doing something, and that's monitoring. And then perhaps for our chief residents or somebody who certainly has credential to the point of mastery, you want to be there but not necessarily in the room with them, and that's called performance with a parachute. You can let them perform, but you have to be in there in case they get in trouble. So in terms of skills in particular, and this faculty development talk on precepting cuts across many areas, but when you're teaching a skill, I think it does bring out the important point that our level 1 newest people need to be watching, our level 2 practicing, level 3 we need to be really close by, and level 4 we have to be there with our parachute, and it's really important in terms of teaching skills. You mentioned something, Marcia, in terms of stress and learning earlier. If residents have no stress, there's not going to be any learning. They're going to be standing around chewing bubble gum. Too casual.
You can't do that. You
can't do that. If there's too much stress, they're going to be so nervous and so overwhelmed they can't remember their own name. So you're right. It's finding that middle ground. So we have structure. They know what to expect. They know we're there for them. They know we'll help them think. But they also know that they're on the spot and they've got to come through, and they have to be efficient in the use of their time. Okay, well, what are the basics, the sort of hands-on? I love this slide because I'm probably the top violator in the department. It's so hard no matter how early I come. But as best you can, it's important to be on time and to really come prepared. But what does coming prepared mean? What does coming prepared mean?
I think it means that your agenda for those 4 hours are to be there and teach. and that you don't have those 10, I mean, you do still have those 10 or 20 things you have to do, but you're not planning to get them done right now.
So coming prepared to you means you're ready when you walk into that suite. You know you're there to precept.
It's your mental
And you're not
readiness.
there. You don't have a waiting room full of patients at that time.
No.
You at that time you're not thinking, wow, I better call on my patients because tomorrow it's going to snow and it's going
Right.
that what you're thinking is, I'm here to work with these residents. What residents are here? What year are they? What
Right.
does the patient load look like? Where are the patients now? You check with the nurses. How's the patient flow going? Why are all these charts here? Why haven't these patients had their vital signs? The residents need to get working. They're sitting in the room. So you're making resident practice and resident teaching and supervision a priority. What does it mean for you? Because you come from other sites. You come from employee health. You come from Lefferts.
Well, I kind of have a routine. When I come in, of course, I'll check with the previous attending who was there before if there's anything left over. I'll start first at the clerk's desk. I want to see which residents I have, or the residents, and how many patients I've scheduled.
What year?
How many have come in already.
Right.
I'll stop at the boxes and check. If there's, like today I went in, there was 6 patients signed in, and there's 4 in the box, and there's 1 patient on the door. So I go to the nursing station, and I'm like,
4 patients away. What's
so
going on here?
I kind of make a routine of doing all these checks first, and then I go to the resident.
And there it is.
Go.
Who's here? What year are they? How many patients? Who's in the waiting room? There's a lot of reasons to look in the waiting room. Not only to see the number of patients that need to be seen, but there's always that clinical check. Is there somebody really sick in this waiting room that we need to triage right away? And every once in a while you walk in and look. And then, as you say, you go to see the residents. And greeting is important. I'll often knock on the day. Hey, here I am. Knock on that door. And I'm your preceptor of the day. I'm here to serve you. Make sure you bring me cases, because if you don't, I'll find you, kind of thing. To greet people, to check things out, see how things are going. And, everybody wants to be that super preceptor. But if you are the super preceptor, the next patient will be waiting 3 hours. So it is that balance
Right.
of what do we need for supervision? What can I teach this resident? And there's also only so much that resident can learn under that circumstance. They're thinking next patient, next patient, next patient. We got to move here, and you're thinking, wow, they've really got to learn about heart failure. And sometimes you get a lot further just teaching them one thing. So we talk about the 5 E's. In fact, all of us were medical students here.
Right.
So all of us learned about those 4 E's. You don't often think about the 5 E's when it comes to teaching. We talked about one already, engaging. That you went in, you let the resident know who you were the preceptor, and you let them know, I'm here to work with you. Enlisting them, letting them know you're there to work with them. I'm being empathetic, and what does that mean?
Well, when the patient, when you feel like they're stuck, you let them know you're there to support them. I have you. Don't worry, you're not going to make a mistake. We're here to back you.
You were in their position before. You know how they feel.
You know how you feel.
As you said, you can anticipate what patient they're going to get stuck on. And there's a lot of empathy involved there, because what would you want done? We're all out to educate, and you want to empower them. You want to make sure that when they go in there, they're confident and they know they have a backup. The environment is something that you often have to control. And the staff will get angry with me. I'll say, no, you all can't eat your lunch in here. This is a room for precepting and teaching. So you even have to sometimes provide that safe space. The culture. We don't know what culture,
That's a big one.
You can go on a patient's shoulder and touch them, and most of the residents will feel comforted. Some resident may feel threatened somehow.
Sometimes there are reasons that the resident reacts to you somewhat differently than other people, and you have to think about it. And we've all, we've talked about this as our whole faculty when we have an issue with a certain resident. Who's the best person to approach that person?
Right.
Who can work with them? Who can talk with them? And it could be the person who's the same gender, the same cultural background, a different gender, a different cultural background. It's not uniform, but sometimes those differences can have a real impact on how you precept.
Sometimes the patient-resident culture difference also.
That's a huge issue for
Becomes
them.
and I find that to be one of the biggest issue that we would have, especially with their food and stuff that they eat and stuff like that. So I always encourage the patient, you have to learn the culture of the patients that you're taking care of. If not, because you can't really reach them to the level where you want to have them partly responsible for taking care of their diseases, like be a partnership with you.
But even as a faculty, when we get together, when we choose an advisor, it's always with the eye to who does that resident function the best with. The point here is that they're comfortable enough that they learn, and they learn medicine. And then we can work with them from there, talking about working with different patients, different preceptors. But you've got to have a good point to start.
Yep.
And, you know, when you're going in and you want to teach, you want to think, you want to prepare, rethink, check your facts, often on computer these days, check your performance, time. Remember that practice makes perfect, and let them know, you know, so you didn't do so well today. The next time you see that, you're going to do a better job. To be patient and to be kind and understand that they are learning. They're residents, they're going to make mistakes. We're trying to get them to understand. You know, if you look like this lady here, the judge, you're not going to get very far. On the other hand, if you're standing around waiting, okay, what are you going to do? Well, that's one way to do it. Let me help you try another. And then think about this. How might you do this differently next time? When we have residents who don't seem to be getting the message, why are we running into clinical difficulties? What are the issues for us? What do we bring to the table? And there are always issues of countertransference. There's always times when we're anxious. We have other things. There's always our comfort level in communication. And teachers are people too. And sometimes, you know, we're the target. We've got the complaining patient. We have the, you know, the nurse who needs. We have the receptionist saying, well, you know, this patient is 2 hours late. You know, this means we're not going to get out on time. And then you have the resident with the backed up patients. So, and you know, as you said, it's a juggling act. So, you know, you need to be all you can as a preceptor. You have to be friendly. You have to engage the resident. You've got to be smart, like, you know, the wise old owl. You somehow have to find that way to keep the smile on your face, because that's what patients and that's what residents are looking for. If we're going to engage them in a dialogue, if we're going to work with them, they've got to feel safe. And by the way, at the same time, you have to be that bright bulb. You have to be a genius. And I think that, you know, precepting really demands a lot. It's not an easy job, but in the department, it may be our most important job.
It's tiring.
It is tiring. Well, if you look at the literature and you look at, you know, what do folks that study this, study teaching, say really makes for a master teacher, they come up with some interesting things. They say, you know, master teachers love what they do. They have a passion and delight for their teaching. They make sure that students and residents feel capable, respected, and important. To know students, to know our residents as people, to understand their personalities. Master teachers focus on the thinking, and that's so important, because nowadays the residents can learn the facts on the computer. We'll have to check to make sure they've got them, but then how do they use them? Do they really understand them? Our master teachers never lose track of the big picture, and they teach what's essential. We know what we see as family medicine doctors, the hypertension, the diabetes, the CHF. What's the understanding behind how we view these diseases, how we evaluate them, how we take a history? And often one of the most difficult things is to go back and get the resident to take a complete history. So you're laughing. How do you do that, Eve?
Most of the time I'll say, you know, it sounds like maybe you need a little more time to get some more information. So let's talk about what are the things you don't know yet that you really need to know to help this person. And then we'll go through like the components of what they need in the history that they just missed. They didn't focus in on it enough, you know, but that gives you a chance to frame it. They say, why don't you go back and talk to your patient for a few minutes? And then I also help them figure out how to make that okay for the patient, because it's weird for the patient for them to come back in.
All of a sudden they come back in and start asking
I'll
questions
say to them,
again.
you know, if I was you, I would say, when I went outside and I reconsidered some of the things that we talked about, I realized that there's a couple things I didn't ask you the first time. So I want to know these things, and then I'm going to step out and check a few things, and they'll come back. Kind of frame it so they have a way to frame it for the patient, which I do all the time. Like if I don't have a result that I want to have and I have to go out and get it, I'll say, you know, I'm going to have to step out and get that, but before I go, tell me A, B, and C. You know, that kind of thing. So it's smoother for the patient. So you're helping them learn how to smoothly acknowledge they didn't really do what they were supposed to do, you know, because of course they're going to forget.
You have a very direct approach. You tell them, look, you need to go back in there and just find this out.
I
or you know, if they've gone, sometimes they've gone like 2 times and come back and still miss something.
Then you have to go in.
And I
you
say,
gotta go in.
I'm gonna come in with you, and I go and I'll introduce myself,
gonna
and I repeat what the resident said to me. I say, but I'm a little bit curious. I just need to ask you a little bit,
Right.
Not make you look like the resident forget,
Right.
but I'm like, I
This
just want to get a little bit more
Something
detail
didn't
or
make
something.
sense to me
So
when
they
I
won't
heard that
look
story.
bad
Can
or
you just
something.
tell me yourself,
Yeah.
right? That's like a...
Yeah. So.
And before you leave the room, I always say, you know, you're very lucky to have Dr. So-and-so.
Oh, yeah.
They
You
really
praise
care
them.
about you. They came and got me, you know, to
Praise
work
them.
with you on this issue. So what does it mean to be an attending? All of us are faculty in the department. All of us attend. And if you look at the Latin word attendere, means to heed. It means to be present, to accompany, to walk with, to take care of, to take charge of, and to listen.
Listen to.
And if you think about it, that's really some of the core practices in precepting. And precepting is difficult. You don't know who's going to walk in. And you have to be willing to say, and all of us have said this, you know, I'm really sorry. I don't know, but let's look it up. You just taught me something. And I remember when I had Justin as chief resident year before the last, and he was saying something. I said, Justin, you just taught me something. I must be a really good teacher. To let them know that medicine is what you learn for your whole life, to be able to say good morning because you want them to feel as though they're important. You know, you've recognized them as people. It's great to work with you. It's easy to say to some residents, harder to say to others. But I find it easier as time goes on. Did I answer your question? Did I really answer your question? Because I'm not sure I did.
Right.
Your question was this, the answer is this. You know, to kind of recapitulate, isn't this great work? And that's the message they need to get. And it's really just not quite teaching. If you look at what McGill and Berkowitz say about this art of precepting and teaching residents, we want a result. We want something that's performance-based. If you look at this guy here, he's using a grappling hook to climb up all those books, and just when he seems to get to the top, he falls back down. We want residents to be knowledgeable and to have skills. We want them to have a good attitude and clinical experience and judgment and to be able to solve problems. But we want them to be mature, self-aware, confident, and to have a sense of family, community, and to really have a sense of integrity. So it's really not quite teaching, but it's also not quite therapy.
It's showing how you do something that they want to do and helping them to find their way to do it.
And we talked about this even in teaching and learning, to think out loud for residents so they understand what were the pieces you put together, how did you put them together, what was your thinking, and how did you come up with your differential and then decide what was wrong with the patient. You don't want them thinking you pulled a rabbit out of a hat.
Nope.
No.
Because they want to be able to look for the same pieces and perform the same kind of thinking so they can problem solve in the future. So I guess the question is, Marcia, who do you empower? The resident or the preceptor?
But I come away with something every time I precept.
Yep.
So you think if you do a good job teaching, you'll learn something?
You learn something. There's something there, no matter how small it is, because the resident will share something with you, even if from their culture or whatever they understand or what, you know. So you learn something.
And while it's not an easy job, I think precepting is critical, and it's one that I really love also. And teaching in general is a joy. You're right.
Yes.
So thank you very much.
Thank you.
It's a pleasure. It's always great to talk with faculty. And we'll meet again. Thank you.
Thank you.
Thank you.
So this afternoon, we had the opportunity to talk about precepting, what it is to be an attending, to supervise and teach our residents and students clinically as they see patients, to think about what it is that we're teaching, knowledge, cognitive understanding, knowledge, medical knowledge, to look at our role as mentors, as people who model, who demonstrate the attitude that we need to properly and professionally take care of patients, to look at our legal and medical role as we supervise and teach our junior colleagues, residents, and medical students in the art of precepting. Thank you.